Our next speaker is Juls Budau. Jules is a master's student at the University of Northern British Columbia. The title of her talk is "What Does It Mean When We Say It Works? User Perspectives on Stimulant Prescribed Safer Supply." Please.
Hi, everyone. My name is Jules, as you just said. I am an OAT and prescribed opioid safer supply patient, and this is an abridged version of my master's thesis research. What does it mean when we say it works? User perspectives on stimulant prescribed safer supply. Which button do I press to make it go? Big one? Okay. So why is this important? Matt talked about this. We have a toxic drug supply in North America. It's very bad. The driving force of this is synthetic opioids, fentanyl. However, stimulant users are dying. Either stimulant-only users with no opioid tolerance are very vulnerable to cross-contamination from fentanyl, or people who are polydrug users, stimulant users, and opioid users have lower rates of OAT retention. And of course, there are also health risks associated with long-term illicit stimulant use. So these risks could be attenuated with a milder pharmaceutical alternative. That would be stimulant prescribed safer supply, SPSS, also called stimulant agonist therapy. So medications commonly prescribed for ADHD provided to illicit stimulant users. In 2020, clinical guidelines were released in BC allowing for the prescription of two medications, methylphenidate Ritalin and dextroamphetamine. However, on record, only about 300 people in the province are prescribed this, despite the fact that we have an estimate of about 100,000 people using illicit stimulants. The reason for this is that doctors often say that the research shows that it doesn't work. After hearing this from a loved one psychiatrist, even though it very much was working for him, I wanted to know what this meant. So I looked into it. Everything written on the subject in the last decade points back to two key reviews, one on psychostimulant drugs prescribed for methamphetamine addiction and the other for cocaine. It's important to note that these include any psychostimulant medications, not just stimulant agonists. So stimulant agonists are actually the minority. Less than half of them in the reviews are on stimulant agonists. Later reviews just on stimulant agonists have different results. They do say that it does show no effect, but a lot of that is because of methodology issues, not from, so it's more because of methodology and high dropout rates, and they do say that the intervention does show some promise. And then what do they mean by working? So generally, are the participants in the treatment group more likely to have achieved full abstinence by the treatment end? And the treatment length is usually 12 weeks, at most 6 months. So I was really interested in what the users of SPSS thought about how it worked, how they defined it worked in the context of their own lives. So that was my master's thesis research. I interviewed 10 people throughout BC. I had a mix of housed, unhoused, urban, rural, and I asked them what it meant for SPSS to work and how do they understand it to work in the context of their lives. So some key findings. So 9 out of 10 participants felt that SPS worked. This was indicated by largely stability, emotional, mental, and financial, which is caused by improved sleep, nutrition, improved mood, mental health. They all discuss reconnection, repaired relationships, increased ability to travel, the benefits of being able to switch over to a non-criminalized substance for their habit. And they all mentioned a reduction or replacement of illicit stimulant use. The sameness of the results was very interesting because they all had very different patterns of use. So only 2 of them had a complete substitution. Notably, one of them took more than 6 months to achieve this and injected his medication. 4 out of 9 were chippers, so they did largely switch over to the medication, but used sometimes. But because of the agonists, the relationship with the illicit stimulants had changed. And they were able to use sometimes and not compulsively like before. 2 of them mentioned use cut in half. For one of them, that meant he no longer had to inject meth at work and could take a medication orally. And one had a stimulant Sinclair method where they would take Adderall at the beginning of the night, where they were at the beginning of the night when they used to consume a lot of cocaine, and because of that, they would consume much less cocaine. So a discussion, it was interesting because only one of those 9 would be a responder if they were if a participant in those key reviews. So because only 2 of them achieved abstinence, but 1 took longer than 6 months, and he injected his medication, he would not be a responder. So the disqualifier is, of course, injecting any use at all, because the use is tested through urinary drug screening, so whether or not they used at all, which doesn't pick up any nuance on reduction of use or stability of use, or they didn't achieve abstinence within the 6 months time frame. So this indicates that the research, these 2 key reviews, are not reflective of the lived experience of stimulant users. So a few recommendations for people doing stimulant research: evaluation of non-abstinence outcomes. So for instance, sleep, caloric intake, frequency of psychotic episodes, level of anxiety or depression, or finding an alternative way to record frequency of drug use. Longer research timelines, which perhaps indicates that clinical trials are not the most appropriate way to measure this. Flexible dosing, allowing people to consume their medication when and how they want. Having injectable SPSS options to reduce the harms of injection of tablets. And of course, you always want an advisory group of current and past stimulant users, or for any research you're doing on stigmatized group, to make sure that they are increasing the validity of your research. Thank you.